minutes. The 1.5 hours, I think, has to be fast-paced now.
So I will tell you two quick things that I would have always done, and I used to do it at Tata's as well when I would take clinics. One is you give the case to 6 to 8 people, and you will choose 10 minutes before the presentation who goes on the air. So that way you have more people. Otherwise, if you give one case to one person, that person mugs up everything, writes detailed notes, and just vomits to us. So you should keep it open to a panel of, say, they're all Hyderabad guys or one from each center. So that's number one. And number two, you should have a panel of students which can be quizzed. So if that one person presenter flounders, the others get a sense of ownership to the program. They also read, they also come forward. And remember, most of what we learned is what we learned at exams when we presented. Those things are still in our mind very, very clearly. So I think two quick things that I can suggest. Of course, I've got other ideas integrating various other things which I'll share with you offline.
Wonderful. I think I was thinking about the second one, but I think you have many more ideas. We will interact, and then you decide after NatCon, Anil, and we would want you to head the faculty anyway. So when you begin, things will settle down. So I think you do that. President has joined actually. I can see him. Yes. Arnav?
Hello? Yeah. My signal, audio signal is not.
Anil, I don't know if you have made out or not. President is a very powerful man, but his signal is generally very weak.
It's better. Is it any better, or can you? We're still struggling. Hello. Hello,
sir. Good evening, sir. Come on.
Kiran, you've lost weight. I mean, are you dieting, exercising?
Yeah. It's intermittent dieting.
Okay, I would not recognize you if I passed you on the street in Ahmedabad. I'm just seeing your name down. I was wondering your face thoda familiar lagta hai.
It's intermittent dieting.
hello.
So you in between, let's say 11 a.m. to 7 or 8 p.m. you eat whatever you want, and then till next day 10 or 11 o'clock.
Hello.
Kiran bhai, I think it is intermittent fasting. You know, the people do in the Western people, they do intermittent fasting. Are you practicing that, Kiran bhai?
Yeah. I'm practicing that.
Hello.
Good evening,
Anand sir, we can hear you and see you as well. It's 7, sir. Shall we start?
Yes, please.
I think so, yeah.
Request everyone to mute if possible. Okay, we are live now. Good evening, everyone. Welcome to the Silver Jubilee inaugural ceremony of the 25th chapter of this series of masterclasses brought to you by ISO Academic Council. I request our President, Dr. Arnav Gupta, to kindly open the session. Thank you.
Thanks, Rajan. It gives me immense pleasure to welcome you all to today's 25th PG Masterclass, which obviously is the Silver Jubilee. You might remember we started on 29th of October, almost a year back, and by this time, thanks to the Academic Council, this is the 25th PG Masterclass, and I must tell you, each one was a masterpiece. I must tell you, all the recordings are on our ISO website, so you'll those who have missed them, you must refer to those links, and you'll find out that the Academic Council has covered almost every aspect of the exam, especially the grand round and the long cases. We might have to change the format later on, so that's something we probably will be discussing. But that will be after NatCon. So during my time, I was honored to have this kind of 25 series of PG masterclasses, and each time we had very good faculties. The examiners had been brilliant, All the topics have been covered, like I said. And at the end of each session, I think that was idea of our convener, Dr. Srijan, that we had a good kind of discussion. So every question that came up from the chat box was discussed. So that was the beauty of it, but I'm sure we can do better. Might have to change the format later on after the NatCon. And today, like I said, this is a special occasion, and we have none other than Dr. Anil De Cruz, who's the president of EICC, to be our chief guest. So before he addresses from his side, I would request our Academic Council convener, Dr. T. Subramanish Rao, to say something. Later on, we'll have all the past presidents who had been in the Academic Council as advisors to say a few words. Thank you, Dr. Subramanish Rao.
I thought it was one of the biggest privileges I've been fortunate to have it seems the academic, the executive committee headed by Arnab Gupta and ably assisted by Sharad Desai and the past presidents, immediate past president, all of them, I suppose, unanimously chose me to be the convener. I think there cannot be a better recognition than this as far as my stint with IASO is concerned. It was very exciting, and I was only anxious whether I'll be able to live up to the expectations. And what I did was I chose one of our best boys who is really well versed with all this, and then very keen to work very hard and very deep into all these activities. Srajan Shukla did most of the job, and if there is credit that has to be given, it is to this boy who organized everything, who arranged the Zoom, and he was after me to select examiners. The selection of the examiners was not easy because you could be blamed of bias. I think the advisors played a tremendous role in this. As seniors, I think they took it upon them and helped me decide who should be ahead of the other good examiners. There are so many in the country. It was just not easy at all. So there is a chance that you could be hurting people. But I think it went on seamlessly and smoothly. Thanks to the IASO Executive Committee. Thanks to the examiners. Examiners have been just amazing, and students have been very sportive. They prepared well so that the whole program goes on seamlessly, and so that time is actually not wasted. The internal examiners have prepared them very well, and all this led to the success of the 25 fortnights program. I really feel redeemed and relieved that the Silver Jubilee function is on, and we have our own Anil De Cruz, a real inspiration and an influence on most of the surgical oncologists in this country, inaugurating it. So I think it's a very good gesture. We have chosen a real luminary, so that the inspiration will extend to the youngsters. I thank Arnab Gupta for this idea and for organizing the whole thing. Thank you very much for giving me this opportunity, President and the members of IASO. I would always be in your service. Thank you very much.
Thanks, Dr. Subramanish Rao. You led from the front, there's no doubt about that. But obviously, we have to acknowledge the other people, all the senior past presidents who had been equally active like they had been during their presidency. So without wasting any more time, I'd request we'll go in turn. So maybe to start with West, Dr. Kiran Kothari, if you are there, just a few words of from your side, your experience from your.
Good evening, everybody. I think this is the 6 month plus in line continuity that we are organizing this master class, and it was really the brainchild of I think present office bearers, plus I think Toprani requested me and all the past president, those who are active, and their names are already there in the academic council. So with effort of everybody, I think we have started this program, which has been really excellently organized and very successful. all the teachers are excellent, including students from all the different institutes. They are participating. And I think it's really very, as Dikru said, that we are really learning each and every master class. We are learning a lot, even at this age, and that's the beauty of this master class. So I wish many more to continue. I think we may be probably, because of the forthcoming conference, we may stop probably this master class for a while, and then again we may start in a different format that we all decide in the academic council. So thank you very much for giving me the opportunity. Thank you.
Thanks very much, Dr. Kiran Kothari. I actually was looking for your, kind of picture on the reality because I couldn't recognize you. Somebody was saying Dr. Kiran Kothari's voice was there, but you have got a completely different look. I think you're prepared for the new look of the PG Masterclass post NatCon. So that's what it appears. Now I move to North. Dr. Arun Chaturvedi, the president, past president. He's also the advisor. If you could kindly share your little experience and your advisors.
So I'm good evening to all the
You lost your audio. Dr. Chaturvedi, we lost your audio. Do you want to come out of your room or something, maybe to an open space?
Dikru's Wi-Fi, if it works.
You're audible now. Yes.
Am I audible now?
You're audible now.
Okay. So what I was saying was that it has been a pleasure and a delight to participate in this ISO Masterclass. And it has been an excellent idea, which has really seen an absolutely new format of teaching for postgraduates. And I would say to the extent that this has been a wonderful experience, not only to interact with the students this way, but also a major learning exercise from the expert talks which have been delivered all along the way. And this repository of long case discussions, I think it's a treasure as an archive. So I thank ISO for giving me the privilege and opportunity to be part of this academic exercise, and I'd be delighted to further, and maybe another season we will, develop new ideas to do it in a much better form also. So thank you very much, all of you.
Thank you very
My
much.
pleasure.
Thank you, Dr. Chaturvedi. Yes, we look forward to the next IPL, maybe the Indian postgraduate class for the next format. We move on to East, Dr. Lalatendu Sarangi, again, former president of ISO, if you want to share your little experience.
He has not joined yet, sir. I think he's
probably tied up. So Dr. Rajaraman, we are going down south now. So Dr. Rajaraman, who has been very active again, please, if you could share something from your side.
Yeah, good evening, everybody. In fact, it was a very great idea from the executive committee to start a meeting like this during the pandemic when physical contact was not possible between the students and the teachers from various institutions. I'm sure a lot of students all through India, both in the MCH and the DPMB, would have been benefited from the knowledge of the best of the teachers in the country. In fact, personally, it was a great privilege for me to be part of the academic council. And also, I must personally thank Dr. Subramanian Rao and his assistant for whenever there was a difficulty in finding out the examiner, Subramanian Rao always used to help me in finding out who's the best in the business. And the Sijan Shukla will always be there to coordinate with the examiners to go about things, both academically and technically for conducting the proceedings. And we had the best of the people in the country I remember Dr. Anil who started with the thyroid cancers as part of the examiners, and it is a fitting that he is there in the 25th chapter as a chief guest. And we must personally thank all the examiners who have been there and all the students who made it a great success. And I thank again the Executive Council of the IASO for giving this opportunity to me. Thank you.
Thank you very much, Dr. Rajaman. I'm sure on behalf of ISO Executive Committee, Dr. Sharad Desai would want to say something. Yeah, we had actually good support from the whole Executive Committee. Even the past presidents, they were all there outside the Accounting Council. So Dr. Sharad Desai, if you want to say something, and then we will move on to our chief guest, Dr. Anil D'Cruz.
Thank you, sir. Actually, today happens to be a very memorable day. We are at a unique landmark, 25 master classes, all it was totally uninterrupted and always very well attended. Basically, we began with an idea to benefit our students. Basically, it was targeted at our students, but definitely the master classes are so worth it that it is useful for almost every surgical oncologist in our country. And I have been seeing many teachers and very senior people attending our master classes. And that has been a very important landmark of what ISO has been doing for this year. The idea of these webinars came especially because of the pandemic. We are always doing webinars, but then we wanted to do something very active for the students. And that is how this whole thing came up with. Medicine, as we always were practicing, was basically we are practicing as science. We are doing research. The conference, we keep on doing research, giving lectures and paper presentations. But till now, we had not done anything which was really something associated with the service or with the clinical activity. And this was one forum which opened up the Indian Association of Surgical Oncology for clinical activity, which we all were very eagerly waiting for. And most of the students were enthused. We have seen the whole response of the whole student community, and we have been seeing a lot of influx into the Indian Association of Surgical Oncology, especially after these master classes have come over the last 1 year. I think we have got around more than 200 new members in a year, which is very, very significant looking at the history of what ISO membership was going through. Of course, we are also getting keen inquiries about master classes, about people wanting to get involved from all over the country, and that is the success of what the master classes have achieved. I also must specially thank and mention Dr. Srijan Shukla, who has conducted these classes very sincerely. Of course, Dr. Rao is always behind him, and I don't want to take the credit away from all the 4 senior past presidents, Dr. Arnab Gupta and many other ISO members who have helped us. But then Srijan Shukla played a very important role for conducting them uninterruptedly, and they were all very well attended. And I must thank him for all his efforts. Thank you, sir.
Thank you very much, Dr. Sharad Desai. So now is the time for the chief guest. So I don't know whether you can give a big round of applause from your side. So Dr. Anil D'Cruz, past director of Tata Memorial Hospital, and is the president of UICC. It's a big honor for an Indian. We are really proud of him. And he was there in the first PG Masterclass inaugural ceremony. Dr. Pawanindalal, a good friend of ours, was the chief guest at that time, but he was there as a special guest and was the chief faculty at that time. So we couldn't think of anybody else, although it was a late decision. Last night we called him up and he readily agreed to help out, to do the honors. So Professor Anil D'Cruz, if you could kindly say a few words on behalf of yourself and.
Thank you.
Thank you.
Yeah. Am I heard and seen, Arnab?
Very much, yes.
Okay. So thank you very, very much for the opportunity to be part of this 25th chapter inaugural ceremony of the IASO Academic Masterclass. I want to start out congratulating the ISO Academic Council, the leadership that includes yourself, Sharad, the organizers such as Sujan and others who really put together a wonderful idea, wonderful concept. And I just believe everybody says COVID changed our lives, But there is a silver lining to COVID, and one of them are these IASO master classes, where we now have a different format of teaching, very well appreciated, as has been said, by students, by our senior colleagues, as well as by the teachers and the experts who spoke on this. I've been asked to say a few words, and I've been asked to say words that could inspire the youngsters. So all I can say, and I'm going to be brief because this is teaching and it's not time for speeches, to the youngsters going for exams and studying for your DNB or MCH, read now, because this is a time when you will read like you will never read again. So read holistically, understand the basics to pass the exam. 90% of you all will pass the exam. And if you only focus on your exam, you will pass, but you will not have read to understand the subject. And if you read to understand the subject, your surgery will become more enjoyable. The way you treat your patients will be more enjoyable. But most importantly, you will make an impact on the science. When I was young, the majority of publications came from the West and we simply aped them. Today, at any meeting, I can see at least 100 to 150 of our colleagues who are good enough to compete with the West. So I would like you all to continue to do this, do small clinical audits in your practice, do little publications if you're in academic large volume centers, and try to change how things go. All of us will become good surgeons. All of us will become good clinicians. But there are other aspects to what we do. There is research, there is education, and there is something called community service, because I sit out at some committees where we promote overseas faculty. They call me as a reviewer and they look at these 4 headings. So youngsters, do good service, but try to take education or community service. And when I say community service, in your own practice, in your own small place, you can do advocacy against tobacco. You can do advocacy for HPV. You can do something on equity. And I think that's what we have to do today to make you all vibrant, to keep you all up to speed with your subject, and to also make an impact on society. And I leave you with the most important message, that please be good, humane doctors. No one wants to be known that he was a successful doctor. But when your children listen to what they say about, they should say that so-and-so is a good doctor, not a successful doctor. Successful doctor is monetary. Be a good doctor and impact on the lives of your patients and influence science. So thank you once again for the opportunity to be part of this inaugural ceremony. I don't want to eat too much of time giving bhashans. It is academics, and that's something dear to my heart. So Arnab, thanks once again to you, the leadership, the academic council, and I'm handing back to you. Thank you for this privilege and honor. It's really humbling to be here as a chief guest among my colleagues, many of them who are luminaries in their own right. So thank you very much for this opportunity.
Thanks very much, Professor De Cruz. Again, a big round of applause from everybody. I don't know whether we'll be able to hear everybody, but it's coming straight from the hearts. I would request Srijan to kindly help Dr. Anil De Cruz in lighting of the lamp, and then we'll proceed with the academics for sure. And our academic council will obviously introduce the faculties for today and their present as well. So Srijan, if you would kindly help with the lighting of lamp for Professor Anil De Cruz. A big round of applause again. Thank you very much. So with that, we conclude the inaugural session once again. Well, I would request Dr. Srijan again to take the PG Masterclass forward and introduce today's examiners through our Academic Council senior advisors. Thank you very much. We look forward to the PG Masterclass. Thanks, Professor De Cruz.
Thank you, Arnab sir. Thank you, Professor Anil De Cruz sir, for his inspiring words. I request Dr. Rajaraman sir to kindly introduce the examiners and the presentee for today, and then we'll begin with our case presentation. You're muted, Rajaraman sir.
Can you hear me now?
Yeah.
Yeah. First, I would like to thank Dr. Sujay Sujikar, with whom I have been associated for a long time, maybe 15 years now. And I know him right from his days where he finished his MS and came and worked as a registrar in the Apollo Specialty Hospital where I go as a consultant. Has come a long way. And I know him personally, how good he is in his academic work. And he is a fitting person to give a lecture on the topic of today. He is Associate Professor of Surgical Oncology at the Center of Oncology at the Government Raipur Hospital in Chennai. And he had his MCS Surgical Oncology at the Kilpatrick Medical College and the Government Hospital, Raipur Hospital. And he won the Snehalatha Endowment Award, the gold medal for the year 2013. He has got special interest in gynecology oncology and he has got numerous publications to his credit. Welcome, Dr. Sujay. And it's my privilege to introduce Dr. Amish Chaudhary. In fact, I gave him a very small time to accept as an examiner, and he readily accepted. He's a director of the breast and gynecology oncology and a certified robotic HIPEC and breast oncoplastic surgeon. He is from the Asian Cancer Center, Asian Institute of Medical Sciences at Hyderabad. Welcome, Dr. Amish Chaudhary. And it's always been my pleasure to be with Dr. M. Ramesh, with whom again I have been associated for a long time. And he is a professor of the surgical oncology at the Madurai Medical College. And he had his MCH from our own institution at the Kilpatrick Medical College in Government Raipur Hospital. One of the first batches, he finished in 2006. And is an active member and participant in all the activities of the ASO and other parts of the ASI for a very long time. He served as a state ASI executive member in Tamil Nadu and Pondicherry chapter from 2011 to 14, and served as a joint secretary and treasurer of the Madurai ASI chapter in the cabinet from 2009. He is currently the vice president of the Madurai chapter of the ASI and is examiner for various universities and different programs. Thank you, Dr. Ramesh, for accepting and welcome. Thank you. Thank you, Dr. Srijan. Please.
Thank you so much, sir. The presentee for today is Dr. Jeevan from Madurai Medical College. A few housekeeping rules for the session. For our candidate, we expect you to give to-the-point answers and keep an open mind throughout the talk. For our dear examiners, this will be a mock clinical examination, the first 60 minutes. So please feel free to interject and cross-examine the candidate throughout their history and clinical examination. In interest of online viewers, both which are live today as well as future candidates who will be viewing it on various social media, we request you to give the expected answers to the questions that remain unanswered or have been incorrectly answered. The case presentation will be given 60 minutes. I'll be reminding the examiners at 30 and at the end of at the conclusion of the case discussion. I request now Dr. Jeevan to kindly share his screen and request the examiners, Dr. Sujay, Dr. Ramesh, and Dr. Amish Chaudhary to kindly take over the session. Thank you.
Good evening, sirs. It is a pleasure. It's a pleasure to be here and be with this case presentation. And it's our pleasure that Dr. Rajaraman introduced us himself. He's our teacher, our mentor totally. So I think Ramesh sir can start and he can start with the case presentation.
Respected Chief Guest of today's Masterclass series and IASO National Office Bearers, IASO Scientific Council Advisors, and one of the member, Dr. Rajaram. Again, it is my honor to be introduced by him. He is our mentor and teacher, and the coordinators of masterclass series, Dr. Subramanian Rao, and convener Dr. Subramanian and coordinator Dr. Shukla for given to us. Once again, I thank one and all. So, Jeevan and Dr. Amis, my fellow panelists, Dr. Amis, would you like to say anything, sir?
So, big hello to all and big thanks to Dr. Subramanian Rao and Dr. Arnab Gupta. And I think it's already late. Let's begin with the presentation.
Sure. Sure, sir. And Jeevan, how are you?
I guess. Good evening, sir.
Yeah, good evening.
Yeah, good evening, Jeevan.
Sir, I'm presenting a case of 53-year-old lady. She's a resident of Madurai, homemaker, married, postmenopausal. She presented to our OPD with chief complaints of bleeding per vagina for 3 months. She was apparently well till 3 months back, after which she noticed bleeding per vagina, initially spotting per vagina 3 months back, where she used 1 pad per day, lasted for 2 to 3 days. She noticed gradual increase in quantity of bleeding per vagina in successive months, where she used 2 to 3 pads per day. No history of passage of clothes, not associated with pain abdomen, discharge per vagina, mass descending per vagina, or mass per abdomen. No history of edema feet or backache, no history of flank pain, no history of any groin swelling, no history of any sciatica.
Just a minute, Dr. Jeevan.
Yes,
One
sir.
more point, post-coital, whether it is associated with post-coital bleeding or not, should also be mentioned.
Yes, sir.
Okay, let's go ahead.
Also, how many years postmenopausal will be of
How many
importance
years?
here?
Sir, patient is 5 years postmenopausal, sir.
You should have mentioned that in your presentation. Okay.
Yes, sir. No history of fever with lower abdominal pain. No history of any hematuria or bleeding PR. No history of dyspnea, hemoptysis. No history of abdominal distension. And no history of loss of appetite and weight. Menarche, she attained at 13 years. Regular cycles for 4 to 5 days out of 28 days. And menopause, she attained at 48 years. Now menopausal for 5 years. Obstetric history, was married at 22 years. P2, L2. First childbirth at 24 years and second childbirth at 28 years. Sterilization done after the second childbirth. She's a non-case of diabetic for 5 years on regular oral hypoglycemic agent and also non-case of hypertensive on medication for last 3 years. No history of other medical comorbidities, no prior abdominal surgeries, no history of similar complaints in the past, no history of hormone replacement therapy or oral contraceptive pills, and no history of prior radiotherapy in the pelvis. She's predominantly non-vegetarian diet, no altered bowel or bladder habits, non-smoker.
Yeah, Jeevan, you should also mention about any IVF treatment taken. Nowadays, it is important
Yeah,
if the
infertility,
case is,
correct.
yes, for any post-menopausal bleeding or
Yes, sir.
any gynecological issue rather taken.
Yes,
Even
sir.
you mentioned about radiotherapy, history of past history of radiotherapy. Have you got anything in your mind? You specifically asked about radiotherapy in a person.
Sir, radiotherapy given to like carcinoma rectum or carcinoma cervix, it has a possibility of causing a radiation-induced carcinoma in the endometrium, as per different articles, sir. That's why I asked about the prior radiotherapy histories.
Is prior radiation to the pelvis a risk factor for endometrial carcinoma?
There are articles suggesting that there is a possibility that after years of giving radiotherapy to the pelvis can cause endometrial carcinomas.
So the best answer would be that it may be a risk factor, not proven,
not
for
proven.
uterine sarcomas.
Sarcomas
rather
are
than-
more chance, yeah. Not
Yes.
Okay, so your first answer should be that probably it may lead on to, it may be a risk factor. It is not proven. Okay, so for uterine sarcomas, it should be first answer, not endometrial cancer.
Yes.
And why did you ask for an okay? And why was the history of OC pill intake? Was it how is it important?
So combined oral contraceptive pills have a protective effect, but estrogen only pills, if taken, it is a
Yes.
risk factor for endometrial cancer.
Very good. Very good.
So predominantly non-vegetarian diet, no altered bowel or bladder habits, non-smoker, no history of high-risk sexual behavior, family history, no history of breast, ovarian, colorectal, and endometrial cancer in the family.
With these specific cancers, we mentioned specifically about breast and colorectal.
Colorectal, endometrial, and ovarian cancer can come in Lynch syndrome, sir. And in BRCA mutations, also ovarian cancer can come. And Cowden syndrome, where P10 mutation, where also breast, ovary, thyroid cancers can come in common with the uterine cancer, sir.
So most
So now we are
important is a Lynch
suspecting a
syndrome.
uterine cancer. But will BRCA cause a uterine cancer?
No, sir. Ovarian cancers and breast cancers.
Okay. And why is that history of high-risk sexual behavior?
As part of history taking, I wanted to rule out whether the bleeding is from the cervix also, sir.
Okay. And smoking?
In this stage,
Smoking, is it of any importance in an uterine cancers?
Smoking is not a predisposing factor for an endometrial cancer, but there are articles suggesting that probably smoking is a protective factor, protective in carcinoma endometrium.
in nature,
Okay.
protective in nature, along with this.
Okay.
Okay, go ahead, Jeevan.
So summarizing my history, 53-year-old postmenopausal lady, diabetic hypertensive on medications with chief complaints of bleeding per vagina since last 3 months, not associated with abdominal pain, fever, discharge per vagina, or abdominal mass.
Okay.
You have completed examination? Okay, examination is coming. Okay.
No, just he has completed the
Come to the history. So at this point from your history, what are you going to suspect before you examine your patient? What are the things that you would like to keep in mind?
It's a postmenopausal lady with risk factors. So I'm thinking about a malignant nature, predominantly carcinoma endometrium, and also I keep in mind carcinoma cervix, even though there is no history of any high-risk sexual behavior and there is no history of any contact bleeding. And I would like to continue with my examination to come to a conclusion clinically what it is.
Anything else which can cause
Why can't it be a simple DU?
Yeah.
Yes, sir. It's a possibility, sir.
Okay. So you can have benign causes
Benign
or any other causes as well. Okay. So back of your mind. Right. Go ahead.
The most common cause of bleeding in postmenopausal bleeding is still atypical endometrial hyperplasia.
Yes.
How many percentage of your endometrial carcinoma presents with bleeding?
So endometrial carcinoma, 10 to 15% of patients may present with bleeding, sir.
10
to 15% of the patients who had bleeding will be because of carcinoma endometrium, and carcinoma endometrium will have 80 to 90% of the patients will present with
the postmenopausal bleeding. That's the way.
Yes.
So your first differential with history alone should not be malignancy.
Okay, sir.
In view of the comorbid illness, still you think in favor of endometrial carcinoma.
Because of the rising incidence, risk factors, and postmenopausal nature, I'm just keeping it in my mind. Same thing. Along with that, I wanted to rule out the benign causes also, sir.
Okay.
Proceed
Let's
with
go to the examination proper.
I think in the chat, there's a question from Ujwala madam. She said that you should ask for a history of exposure to tamoxifen.
Yes, sir. Okay, sir.
Yeah. But anyway, since you talked about breast cancer and all that, So do you know the association between tamoxifen and endometrial cancer? I guess.
Yes, sir.
Yeah, you can go on to examination.
I examined the patient in the presence of a female chaperone. She's of performance status PCOG grade 0. Patient conscious, cooperative, well-oriented to time, person, place, and moderately built and nourished. BMI of 33, fair hydration. Pallor was present. No icterus, cyanosis, clubbing, generalized lymphadenopathy, or pedal edema. Vitals.
One question: when you said the BMI is 33, is it moderately built?
She is short and obese, actually. Sir.
Yeah. So it should be at least well built. Or
well built, yes.
Yeah, I think that will go in favor of your diagnosis again. Right.
Febrile pulse rate 80 per minute, regular BP 120 by 70 millimeters of mercury, and respiratory rate 18 per minute. Examination of abdomen. On inspection, shape of the abdomen is flat, umbilicus central in position, inverted. All quadrants move equally with respiration. A midline horizontal scar of 3 cm healed by primary intention, which is situated 10 cm inferior to umbilicus. Stria was present, and no visible peristalsis, pulsations, or engorged veins. Flanks free. Hernial orifices are normal. On palpation,
can I just, sorry, I'm interrupting you. On inspection, do all quadrants move equally with respiration?
Upper quadrants usually move with respiration, sir. Most.
Yeah, corresponding quadrants move
Yes,
equally with
equally
respiration.
with respiration. Yes.
A better word, yeah.
Yes.
Yeah, go ahead.
On palpation, soft, non-tender, no mass palpable, and no organomegaly, no fluid thrill or shifting dullness. Normal bowel sounds were auscultated. Proceeded with the per speculum examination. Cervix was normal. Null fornix is normal. With the lubricated finger, pervaginal examination was done. A bulky retroverted uterus. Cervix showing no nodularity or ulcers. All fornices free. Normal vaginal mucosa. Blood staining of gloved finger. And per rectal examination, external sphincter tone was normal. Normal rectal mucosa. On bimanual and bidigital palpation, bilateral parametrium were supple, and no POD nodules. And no supraclavicular.
How you can have blood staining of
If
glove
your
finger
glove
if your
finger,
PS is normal? You can't have blood staining of glove finger if your PS is normal.
If there is no discharge from the cervix
Yes,
on
sir,
your per speculum
those-
examination, how did you have a blood stain discharge on your per vaginal examination?
I had a slight staining of my glove finger while examining, sir.
So
How will you
if,
substantiate
so,
that?
so if your PS is normal, avoid using this line.
Okay, sir.
Or mention some blood clot from the os.
Yes, sir. Yes, sir. Yes, sir. It was actually blood clot from.
Yeah. Or mention some retained blood inside vagina. Okay.
Yes, sir.
Or otherwise avoid this line. Nobody will notice. You can avoid this line.
Yes, sir. Other systemic examination were essentially normal, sir. Summarizing my case, a 53-year-old postmenopausal lady, non-diabetic hypertensive on medications, with chief complaints of bleeding per vagina since last 3 months, not associated with abdominal pain, fever, discharge per vagina, or abdominal mass. An examination, obese, performance status ECOG is 0, pallor with no abdominal mass, and irrelevant clinical PV examinations.
Okay.
So with this history and clinical findings, what could be your clinical diagnosis?
Sir, keeping possibility of carcinoma endometrium in the above, and I'm also keeping a possibility of atypical endometrial hyperplasia also. Endometrial hyperplasia also as a probable diagnosis.
So you meant to say it's another benign disease other than C endometrium.
Both I'm keeping as a thing, and more in favor of a carcinoma endometrium because of the age and risk factors.
Okay, age is just 53 only,
Age is
not just
53, yeah. See, we all know this is a C endometrium class, so you cannot go with your this thing saying that this is C endometrium. That is what we are all trying to impress on you. Exam also, this is what always happens. You need to have an open mind, and you try to rule out other things before you actually jump into your diagnosis.
Any other thing which can produce a postmenopausal bleeding other than these endometrial hyperplasia and C endometrium? Have you got anything in your mind to say about causes for postmenopausal bleeding?
Atrophic endometritis can cause bleeding, and also endometrial polyps, cervical polyps, and vaginal atrophic vaginitis.
Okay.
Can cause
Retain, yeah, fibroids, retain IUDs.
Yes, sir, fibroids and retained IUDs.
Yeah, if you sit in OPD long enough, you will see all kind of things. So.
And anything else? Did you examine for the ovaries? Any other mass which you look for in the abdomen? Any other thing outside the uterus that can cause postmenopausal bleeding?
Sir,
any other thing? Extra uterine causes.
Where the estrogen secreting tumors of the ovary, like granulosa cell tumor, can also cause.
Okay. And any bleeding, systemic bleeding tendencies? Huh?
Yes, sir.
Systemic bleeding disease. Okay.
Yes, sir. As patient had it for a short duration.
Here you said only 3 months duration, no?
Yes, sir.
But no bleeding manifestations for other sites of the body, anywhere else.
No bleeding manifestations.
Okay.
Otherwise, there are all, like Dr. Ramesha said, you can have all lot of things we have seen in OPD: hematological disorders, low platelet counts, patient on antiplatelets, drugs for other reasons. So yes.
But here this patient is
as per the history and examination, we have nothing much to suggest toward any diagnosis.
Okay.
It's a wide open case. Actually. We have nothing to suggest whether it is benign or whether it is malignant.
True.
So
yes, there is no finding even in the clinical examination. Abdomen, there is
so
no
in such a case, it is better to give an answer that there are several causes. I would like to rule out by further investigation. I don't have much leading pointers for any one diagnosis.
Yes.
Yes. If the examiner says, okay, list the possible diagnosis, then you give a list. Otherwise, you should say that, sir, there is nothing much to suggest either in history or examination towards any particular diagnosis. There are a list of number of diagnoses that can be possible, and it would be better to proceed with investigations.
Yes.
Okay, so what are your diagnoses right now?
Right now, I wanted to rule out by extending my investigation as a first line investigation. I wanted to do as an extension of clinical examination to do an ultrasound, transvaginal ultrasound, and also the ultrasound abdomen and pelvis.
What is the advantage of transvaginal over transabdominal?
Transvaginal ultrasound can find out the uterine size, the endometrial thickness, adnexal mass to an extent, and
you can't make that all out in the transabdominal ultrasound.
Endometrial thickness is better seen in the transvaginal, sir. So, as we can take the sagittal's view in the ultrasound.
Endometrial thickness you cannot make out through a transabdominal, is it?
Can measure, but more reliable on a transvaginal.
Do you think all patients who have a postmenopausal bleeding first go for a transvaginal? Yes, you should have a transvaginal probe.
Transabdominal, and when they see the thickness to measure it completely, to go for a transvaginal.
Yes, TVS should be one of the first investigations.
Okay.
That should be ordered along with a.
Nowadays, we can consider it an extension of clinical examination.
Okay. So you done an ultrasound.
Yes, sir. In this case, actually, the endometrium was thickened, and they were not mentioned the exact thickness, and they wanted to continue with the further investigation. That was the radiologist opinion, sir.
No, wait.
So how can they not make the thickness?
See, first of all, we should be clear that in ultrasound report when comes that you have to read what is the adnexa, what is the size of the uterus, are there any associated fibroids or not? Okay, how much was the bladder got filled? Okay, in TVS there are a lot of information except endometrial thickness.
Yes, sir.
What is the complexity of the endometrium? Okay,
yes.
Thickness is one thing, complexity is another thing, vascularity is another thing.
Even the cervix. How is the cervix? Everything is to be.
Yeah, polypoidal mass is another thing. Okay,
yes.
And any loss of interface of the endometrial myometrial junction is also mentioned in
transvaginal ultrasound. Yes, yeah.
It is all these factors are mentioned in every routine TVS, and you must have a look at all these lines, whether it is a TVS or MRI. Okay, so when you're reading a TVS, you must look at all these things. When you are looking at an MRI, you should recorporate these things on MRI. Okay.
There is a question from chart.
So can you repeat all the factors that we have to
look for in your ultrasound?
Repeat it quickly. 1, 2, 3, 4. Quickly repeat.
So in an ultrasound, uterine size and the echogenic complexes in the endometrium, the vascularity and the endometrial.
So first, begin with adnexa.
Adnexa, yes, sir.
Adnexa, uterine size, associated fibroids.
Associated fibroids, polyps.
Then come to the endometrial lining.
Yes, sir.
Okay, bladder. Okay.
Yes, sir.
And then come the endometrium.
Okay, sir.
Okay.
Yes.
Okay, Jeevan, there is a question from the chart. How the postmenopausal endometrium will look like?
Sir, it will be like it will be more of.
What is the normal thickness?
Yeah, what is the thickness you expect in a postmenopausal?
Thickness normally is less than or equal to 4 mm, sir. Normal conditions, sir.
Okay. So anything more than 4 or 5 millimeters should be investigated.
Yes, sir. More than 5 mm with bleeding should be investigated, sir.
In postmenopausal?
Postmenopausal bleeding. Postmenopausal case.
In premenopausal, what do you look for? Endometrial thickness?
Premenopausal, it varies between the cycles, sir. So it's a cycle specific.
So when will you measure the endometrial thickness in a premenopausal woman?
It is in the secretory phase. Will measure.
You measure in the secretory phase or in the postmenopausal? Sorry, postmenstrual phase.
Post-secretory.
If you want to look for endometrial thickness, we are talking
Uh,
about for bleeding, DUB. We're not looking for I think
So
infertility.
Post-menstrual phase.
So immediately post
Menstrual, yeah.
menstrual phase.
Okay, so what was the ultrasound findings for your patient?
Sir, the ultrasound was done actually from an outside center. Sir, they have mentioned only the thickened endometrium, and I commented there was no adnexal mass, no cervix mass, and there was not much of information in the ultrasound. So we continued with the office procedure and then MRI investigation. Sir.
Would you not ask for a repeat ultrasound if your ultrasound was satisfactory? What would you ask? Okay, you haven't. What would you ask your radiologist specifically when you ask them to do an ultrasound for endometrial? You're suspecting an endometrial thickness.
We need to know the endometrial thickness, also the echogenic complexes, and as we discussed, the adnexal mass, any polyp, the vascularity, all those things.
And like
ask
sir
the
kept
radiologist.
mentioning, I think Amish sir was telling you should ask them to look for the endometrial myometrial interface.
Interface, yes, sir.
Yeah, on your transvaginal ultrasound. Okay.
So along with this, we will do almost all the blood tests that are required. There's no need to go in detail for that. There is no specific blood test that is required. Some people may ask you any tumor marker would you like to do. As of date, the answer is if there is no adnexal mass, there is no need to do any specific tumor marker. That is what my practice and understanding is. I would like to ask the other examiners whether they would like
I think
to
it's
get
agreed. So if you have an early
other
disease,
tumor marker.
Sometimes in the serosal histology,
then you can look for a
non-endometrial like
histology. We don't
serosal.
know as of now, sir. We don't know histology as of now.
At this juncture, we don't know about the tumor
There is
markers.
no, yes. So that is what I am trying to say. If there in the absence of an adnexal mass, a suspicious adnexal mass, there is no need to order
tumor marker, CA or
tumor marker
like you said, yeah.
on this ultrasound report. Okay. So now the next question is, how do you confirm your suspicion?
I'll continue with the people endometrial biopsies.
Endometrial biopsy, EB. Yes.
Yes,
Yeah. EB, office EB is now a accepted procedure.
Yes,
for,
yes.
And it's a very comfortable and OPD procedure, and wherever it is available, it should be done.
Yes.
Okay. So now the next question is, how do you differentiate whether you will opt for EB or whether you will opt for a hysteroscope? How do you decide? What is the indicator in the ultrasound report that gives that in this case I will opt for this, in that case I will opt for that? There are few things.
When will you choose a hysteroscopic biopsy?
When the endometrial growth is very small and we need a focused biopsy, then hysteroscopic biopsy curate would be
yes.
better.
So what in which condition we need a focused biopsy? In which condition? So in case if your endometrial thickness is not
uniform,
thick enough, and there is a polypoidal growth rising from one side of the uterine wall or from the fundus. In that case, EB will reveal nothing.
Okay.
Okay. In that case, you will have to go and do a proper curettage. Only then you will get the required sample.
Yes, sir. Understand.
All right. Otherwise, EB alone is enough.
Yes.
Okay. So now give us the finding of the EB.
Sir, it showed tumor cells arranged in papillary.
What else? What else? Only EB alone is enough.
When you do your endometrial biopsy, will you do something?
There is one test which has to be done on almost every woman visiting a
pap smear. Pap smear also should be taken.
Pap smear should be taken. And which one will you take? LBC or the normal pap?
Liquid-based cytology or normal pap?
Normal pap.
Normal pap, sir.
Yeah, normal pap can be done, but it is preferable to do LBC if her last pap smear report is either not available or it is more than 3 years of 3 years.
3 years of doing your pap.
Okay.
Yes, sir.
Then you can. Then, if you are repeating within 3 years of the last pap, then the normal pap will suffice.
Okay, sir. Yes.
Why it is important to do pap?
Because to find out whether the possibility of the cervical extension and also the carcinoma cervix possibilities.
Cervical extension on a pap.
We are not bothered about cervical
extension on a
cervical,
pap.
cervical carcinoma also, sir.
Cervical or any pre-malignant stage.
Yes.
Okay. Not necessarily cervical carcinoma.
Can an endometrial carcinoma show up on your pap smear?
Endometrial cells can come in the endocervical pap smear. Sir.
Yes.
We take from ectocervix.
Endometrial carcinoma itself.
Carcinoma will not
Yes.
come. We'll have a suspicion.
Yes, you can.
Only.
No. You can make out malignant cells because they are coming out through the vagina. You
And
can
your
make out
answer is partly correct. In the EC brush and the endocervical brush, you can get cells from endometrial carcinoma. And it is wrongly reported as endocervical cancer in the biopsy report. And when you get the radiology done, the mismatch, the origin is from endometrium.
Yes.
Okay. So
Yes, sir.
okay.
So there's a question in the panel. I think somebody has asked: will you do a cervical biopsy when you're doing an endometrial sampling?
No, we'll not do a cervical biopsy, sir.
Okay.
Yes, there's no need.
If it is normal on examination, you will not do a biopsy. Right.
Yes.
Go ahead.
Okay.
So,
but pap smear is mandatory. Okay.
yes. Section studies show tumor cells arranged in papillary and glandular pattern and irregular crowded glands with minimal stroma arranged back to back, exhibiting high cytological atypia, increased mitotic activity, areas of hemorrhage, and features suggestive of endometrioid adenocarcinoma.
Okay. And
So are you happy with the report?
grade? What was the grade?
Are you happy or it is
Is it incomplete?
It is incomplete, sir. I would like to know the grade also in this case, sir.
further will you repeat the biopsy or will go for FNC or at this stage just it is enough? Do you think?
I will discuss with the pathologist to confirm the grade and
yes.
Also because that will help us in the further management of the cases.
Further management, yes. So grade is one of the most important factor in risk stratification, whether it is low risk, intermediate risk, high risk. Okay, so grade is important. Do you think grade can change with the first and the final histopath? What is the disparity rate between the
between your biopsy and the final post-surgical histopathology?
Sir, around 10 to 20% changes can happen.
So I think world over it is close to more than 20% disparity between the initial and the final,
especially when it is grade 1.
Yes, yes. So
yes.
So it generally it can upstage in the final histopath specimen.
Generally, yeah.
Generally it can upstage, and in case it downstages, you have to treat as per the highest reported grade.
Yes, yes.
Okay.
Okay. Whether it is EB or histopath, whichever is the highest reported grade, that will be taken into consideration while doing the risk stratification. Okay. So now after this report, what radiology you will order more?
I'll order for MRI pelvis.
MRI pelvis. Yes. MRI pelvis. Why pelvis?
MRI abdomen and pelvis, sir. And pelvis
yes,
mainly
abdomen
and pelvis. Yes, sir.
Yes, MRI whole abdomen and pelvis should be ordered. Whereas if she's undergoing MRI, do the entire study. Okay.
Yes.
So now name 1, 2, 3, 4 the things that you will see in MRI quickly.
Yes, sir. We look for the lesion and the endometrium, sir.
So remember this. This is my formula in any surgical oncology case. Whenever you are reporting radiology, whether it is CT, MRI of any primary, always follow the TNM pattern rather than the way radiologists report. Okay, radiologists have a system of reporting so that they don't miss things. For a surgeon who is appearing in exam and as well as in your practice, always follow TNM. Okay, what are the things which will allow you to operate? What are the things which will give you the decision on how much extent you have to operate, and what are the things which will stop you from operating? Okay, so this is make it a practice for all cases, not only endometrium. Whether you are seeing breast, esophagus, HCC, gallbladder, rectum, always try to report in your OPD also. Look at the image as a TNM. Okay, first go and look at your primary site. Okay, that and so name the thing that you will see in primary site. They are same as ultrasound. Name fatafat.
Yes, sir. It is first we'll look at that nexa, then the uterus per se. In that
Uterine size, flexion,
uterine size,
antiflexion, retroflexion.
Yes.
Okay.
Yes, sir. And the tumor, the site of the tumor in the endometrium.
Any myometrial mass, any adenomyosis. Then comes the endometrial thickness.
Yes, sir.
Then
Uterine
complexity,
fibroids.
vascularity, polyp, and interface.
Yes, sir. Interface,
Yeah.
the endometrium myometrium interface also we see, sir.
Site of origin of the tumor, whether it is fundal, whether it is from body, extension into the lower uterine segment, what's the cervical stroma, okay?
Yes,
and
sir.
how does the cervix look like, any extra uterine disease, okay? In this order, you have to read your MRI. Whenever you see MRI, read in this order yourself.
Okay, sir.
Okay. Then pelvic lymph nodes, then para-aortic nodes.
Lymph nodes.
Okay. Then momentum, then liver, peritoneal surfaces.
Yes, sir.
Okay, na? And then finally fluid, if there is some fluid inside.
Fluid in the abdomen, yes.
Okay.
Yes. So this is actually, sir, a sagittal section of the pelvis shown, where in the T1 there is a hypointense mass lesion seen in the endometrium, which will be characterized more in the T2 lesion, T2 phase, where
What do you notice in a T2?
Yes, sir. T2, sir, this is like iso-dense image, that is the endometrial tumor, where there is a small interface, that is the hypodense area, hypodense area between the endometrium and the hypodense area. This is the
it's
the
intense,
junctional.
okay? On your MRI, it's intense. Right.
Yes, sir. Intense. Intense, sir. This is the junctional zone, hypointense area. That is the inner myometrium. So in the fundus area, it was seen, but in the other areas, it was not well seen. And and after that, one isodense area seeing, that is iso-intense area seeing, that is the outer myometrium. So there is a focal invasion of the tumor into the myometrium. But to differentiate well, we need a contrast enhanced MRI, which will light up the myometrium so that we'll know where exactly the myometrial invasion and how much far the myometrial invasion is. And also we'll look for the vascularity. And then in this case, there were no fibroids, serosal, subserosal fibroids is seen. And also then we look for the cervix.
Okay.
So this is the cervix area and the endocervix region, but there is no growth extending to the cervix as per the MRI. It was just coming inside the body of the uterus only.
Okay. And also, you must also see the interface between bladder and rectum, whether the fat planes are maintained or not.
Yes, sir. Here the fat planes are maintained between the bladder and the
yes, they are maintained.
and rectum. Yes.
They must be done for any hysterectomy case. Okay.
Yes, sir.
Fat planes important. Okay. Even if it is benign, you must see the fat planes. Not
yes,
for
sir.
oncological purposes, but for surgical technique. Okay. So, what about pelvic lymph nodes?
Sir, in the axial planes, we looked for the pelvic lymph nodes. There are small pelvic lymph nodes are seen, which are less than 1 centimeter, 2 or 3 on both sides were seen. But I have not added the image, sir, and there were no para-aortic lymph nodes seen as such, sir.
Okay, okay. So, what are the more common lymph nodes, pelvic or para-aortic in endometrial malignancy?
In the body of the uterus, more pelvic lymph nodes are common.
No, irrespective of site, it is
pelvic is common.
Okay.
Yes,
Now, next question is what is the skip mat to the para-aortic? That means to
What
have
is
a
the
para-aortic node
chances of
without having a pelvic lymph node.
Fundus having the high chance of skip metastasis, and without
Forget
having
about
a
site.
Forget about
yes,
fundus.
It is not dependent on site.
Okay, sir. Without having a pelvic lymph node, there is only 1% to 3% chance for skip metastasis.
less than 5%.
Yeah, that yes. So in YY you have to say less than 5.
Yes.
Less than 5.
Less than 5. Okay.
So we have another 25 minutes more, sir.
Yeah.
So what are the chances of having mental disease?
Sir,
Mental disease.
mental disease are seen in mostly in the non-endometrioid histologies like
Very good.
Okay.
Yes.
carcinosarcoma, serous
Serous
carcinoma.
and
Serous carcinoma, serous clear cell.
serous clear cell and
and
carcinosarcoma.
Sarcoma.
These are the three histologies in which omentum metastases are common. In all other histologies, omentum is very
we don't
very
expect
rare,
that.
very rare. Okay.
Yes.
So there is
Yes.
no fluid. So all this is okay.
Yes, sir. No fluid in the.
Yes. Okay. So okay. So before the MRI, yes, one point we missed. What is the current status of hysteroscopy, pre-op hysteroscopy, DNC on the survival, on the recurrence pattern and survival? What is the current debate in the world? Whether it should be done or whether it should be totally avoided, or it can be done.
Hysteroscopy can be done, sir, but it has same time the complications like passage of the malignant cells to the transtubal spread.
So
what does it cost?
This is a theoretical concept
Yeah.
that it may increase. Multiple studies from multiple continents
have
shown with
no
very
such
long-term
on
follow-up data that
there
it
was
has
no
not
such.
led to any deterioration of overall survival.
Yes.
Okay. Even if
It's only a theoretical part.
peritoneal cytology to be positive at the time of hysteroscopy, at the time of hysterectomy, it does not impact survival.
Yes.
Okay.
Yes,
Simple
sir.
answer. Okay.
Yes.
It can be done. It's not a contraindication.
Okay, sir.
Okay.
Yes.
So that is why they skipped it in the figure stage, the peritoneal cytology. Okay.
Yes, sir. And Dr. Ramesh, can you come again, sir?
Yes, sir, we can go more. So,
Yeah.
Okay.
So now,
So-
based on MRI, what is your final report and what do you want to do next?
I wanted to plan the patient for a staging surgery along with the total abdominal hysterectomy and bilateral salpingooprectomy. So I'll
So
counsel
clinically, what are you suspecting? Clinically, what is your stage that you are suspecting based on your
clinical
MRI?
stage.
clinical stage, sir. It is infiltrating invasion into the myometrium. So more than 50% as per the report, sir. So clinically, it is stage 1B, sir.
1B.
1B and
So we don't know about the grade at this time, sir. In this case, in this particular case. Okay.
Okay.
Yes, sir. So I'll talk to my patient about the plan, and I'll counsel the patient what the surgery is going to be done. And with the informed consent, I'll plan for rest of my investigations for the fitness for surgery. And after a pre-anesthetic checkup,
which surgery you will
Surgery
advise?
planning.
Lap or open?
In this case, we planned open surgery, sir, because of the bulky uterus.
Yes, bulky uterus and okay, yes, it is preferable. So, what are the indications for minimal access surgery in endometrium? Quickly, fast.
Stage 1A confined to the endometrium or less than 50% myometrial invasion, tumor size small, non-bulky uterus.
And favorable histology.
Favorable histology, yes, sir.
Favorable histology.
Okay.
Is there any trials supporting your
Laparoscopy is supported by LACE trial. It showed there is equivalent overall survival and disease-free survival with the laparoscopic approach in the early stage cancers. And also GOG Lab 2 study that also showed a quality of life after the laparoscopy is better when compared to open. And there was not statistically significant difference in the overall survival and the disease-free survival.
So up to what stage can you plan for laparoscopy?
Up to stage 2, sir.
Up to stage 2. Okay.
So it can be done in stage 1B with grade 1 or grade 2 tumors also it can be done.
Yes, sir.
Okay.
Grade 3, yes.
Grade 3 generally should not be done. There people have seen higher recurrence rates. Although there are papers from single institutional studies showing equal survival in grade 3 also. But generally, I don't think in India it is practiced. It's not in my practice to do rest all. Okay, so what is the extent of surgery that you have planned? Open radical hysterectomy?
You just confine with the TAH with bilateral salpingooprectomy, or you will go ahead with the surgical staging proper?
Sir, I'll do extrafacial hysterectomy and bilateral salpingooprectomy.
No.
And after that,
okay.
You have to do first cytology inspection of the omentum. You
Yes,
have to
sir.
take peritoneal washing.
Yes, sir.
Yes.
Go with the
Systematic.
midline, lower midline incision. Laparotomy will be done. After that, we'll take a peritoneal cytology and also look for any peritoneal disease in the peritoneal diaphragmatic area and all the serosal surface. After that, any adnexal disease or adnexal breach is there also we'll see grossly. Then proceed with the extrafacial hysterectomy and bilateral salpingo-oophorectomy, followed by pelvic lymphadenectomy.
So tell me, in what indication you will do which type of hysterectomy? Type 1, type 2, type 3. In which indication of CA endometrium? Only CA endometrium. In which one? Which indication? Indication type 1.
In stage 1, we'll do type 1 hysterectomy, sir.
Yes, you can.
In stage 2, that is with a cervical stromal invasion, we'll do type 2 hysterectomy or type.
So all examiners agree that if cervical stroma is invaded, then type 2 is enough.
Type 2 or proceed with type 3, sir. Or instead, we commonly do with the type 2.
Yes, because there is no involvement of the parametrium. Type 2 also should be enough. Okay, yes. But generally, yes, but for practical purposes, there are only 2 types of hysterectomy that I know that exists. Either it is type 1 or it is type 3. Type 2, I have never been able to do a type 2. So okay, so in type, so if the cervical stroma is involved, you should do a type 2. Okay. So what is the extent of lymphadenectomy that you will do?
Lymphadenectomy will do.
Extent of lymphadenectomy in this case, and then we will talk for all other cases.
Okay, sir. In this case, because pelvic nodes were seen, as we didn't have a central lymph node facility, we proceeded with a complete pelvic lymphadenectomy on bilateral side and looked for any enlarged nodes in the para-aortic region. And
yes, para-aortic must be explored in all cases in which you are contemplating completion lymphadenectomy.
Yes, sir.
Would you do a para-aortic sampling if you have any enlarged nodes?
Enlarged nodes, yes, sir. Sampling can be done, sir.
Yes.
So do you inspect it or do you actually open your peritoneum?
If there is a line node, do a completion para-aortic.
Yeah, would you do a completion or you do a sampling? What is required?
Sampling is required, sir. After that, we can go with adjuvant therapy, sir.
Okay, up to what of the para-aortic would you like to inspect and remove? What extent of para-aortic nodes?
So up to the renal vessel.
Okay, renal hilum. Okay.
So would you do para-aortic node dissection in all the cases, including a stage 1A disease with low grade? In all cases, do you advocate para-aortic node sampling, or you will focus in select cases?
Yes, sir. In select cases, we'll go, sir, with the high grade, that is grade 3, high risk histology, and also with the deeper invasion of myometrium. In such cases, we'll go with that.
Okay. So also the omentectomy. Okay. What about
with
the non-endometrioid histology, sir?
Yes.
Okay.
So now indication of central lymph node quickly.
So stage 1, grade 1 or 2, stage 1A.
Yes, very good.
Whether you will advocate sentinel node biopsy in a low risk category or high risk category, high risk cases.
Low risk category, sir, because they have a less chance of having a node. So sentinel lymph node biopsy would be better.
Okay. Yes. So yes. So it is the indications are stage 1A, grade 1, grade 2, stage 1B, grade 1. Okay. And
yes,
no enlarged lymph node on radiology. Okay.
Yes, sir.
Yes,
this is the indication. Okay. So
yes,
what is the most preferred dye?
Now the most preferred dye is indocyanine green, sir.
Yes, ICG is considered now the best. What is the pickup rate of ICG?
Pickup rate is sensitivity is around 97%.
More than 95%.
95%
is the pickup rate of ICG. And what is the second best dye?
Second best dye is blue dye, sir.
Methylene blue. And what is the pickup rate of methylene blue? Average
around 90%, sir. 90%.
It is less than 90%.
It's not 90. It's 86.
80 to 90% is the in when you are highly trained, it may touch 90, but otherwise it's around 80%.
Yes.
Okay. So
where will you inject?
Where do you inject? Yes. Where do you inject?
Yes, sir. The common location is current is in the cervix, sir, at 3 o'clock and 9 o'clock position.
Yes,
sir. And
how much deep you have to go? The needle?
The superficial and also deep, sir, submucosal, sir.
Deep, how much deep you
about 1 centimeter into the cervical stroma, and the needle must travel outwards.
Outwards, yes.
Yes, slightly outwards, so that you reach the close to the parametrium for faster
sir.
diffusion
Sure,
of
sir.
dye. If you go straight in or towards medially, the pickup rate will be very less.
Yes, sir.
Okay. Okay. So, what are the three pathways of central lymph node? The three pathways that you have to. What's the technique of central lymph node? There are three pathways.
Yes, sir. So in the first pathway, sir, it follows the uterine vessels.
Yes,
and
uterine
then,
vessel.
And
Yes,
then
yes.
it crosses the obliterated umbilical
artery into the pelvic lymph node. Basically.
into the pelvic lymph node area.
So the incidence of this pathway is 90%.
90%, yes, sir.
Yes.
Commonest
Okay.
one, yeah.
Yes.
Sir,
And the second pathway?
Second pathway is some lymph node will not pass the obliterate umbilical and it passes along with the mesoureter and deposits
Mesoureter.
presacral common iliac node.
Yes, yes, very good. So what's the incidence of this? About
This
7
is
to 8%.
7 to 8%, yes, sir.
Yes, okay. Now then the third pathway?
Third pathway is along the ovarian
Ovarian vessels direct into the paraortic. The incidence of this is 1%. Okay. And uncommon sites, uncommon pathways, 1%.
1%.
Presacral, prevesical, pararectal. Okay. These are
Yes,
uncommon sites. Okay.
Uncommon. Yes.
Suppose if the dye is not taking up the pelvic lymph nodal areas,
What
no
will you do? Yeah.
concentration, no.
You're not able to make
Very
out
good.
any area which is any node which is picked up on your sentinel node.
Yes, sir. Any suspicious node is there, that also can be picked up. If one side is not lifted up, then that site-specific lymphadenectomy should be done.
Should be done.
You inject once, it doesn't pick up. You'll do a site specific or you'll do something else.
Tracer repeat can also be.
Yeah, you can repeat up to twice. Okay.
Yes.
Okay. So once you have harvested the node, then what do you do with it?
We'll send for frozen section biopsy.
Now, what is the current standard? Current standard
Is frozen section
or
of the
ultra
node
stage?
standard or is it something? Yeah, Alexa is asking.
Ultra sectioning of the lymph.
Ultra sectioning, ultra staging.
Ultra sectioning.
Ultra staging.
So
What's
if
the
you do
difference between?
if
Yeah.
you do a frozen, you cannot do an ultra stage. Okay, so frozen section was initially the best way of doing handling the things. Now almost all centers have moved on to ultra stage.
Ultra stage.
Okay.
Why did they move on to ultra stage instead of frozen?
Because along with H&D staining, cytokeratin IHC also can be done, and 3 mm sections can be done.
First of all, ultra staging helps us to pick up the more
improve the yield rate.
Secondly, it was seen that doing completion lymphadenectomy based on frozen section does not impact survival.
Yes.
Okay, because your adjuvant therapy remains the same. Adjuvant therapy will offset any micromet that is left in lymph node basin, and it was seen by multiple centers that it does not impact survival whether you do a completion lymphadenectomy based on frozen section. So it was seen that instead of missing few patients who are actually node positive but reported node negative on frozen section, it is better to do ultra stage and pick up almost every patient who is node positive.
Okay.
Okay.
Yes.
So because in frozen section, if the lymph node is positive, you will do a completion lymphadenectomy, no. But in
Yes,
ultra stage report comes much
You do
after
not
the
need to.
Much
patient
after
is
that.
discharged.
Yes.
Okay, so if the ultra stage report is positive for micromet, would you go in and do a completion lymphadenectomy, or there is something else that you can do?
Will subject to adjuvant pelvic radiation.
Yes, there is no need to do a completion lymphadenectomy if the report is positive on ultra stage.
Yes, sir.
Okay, you can proceed with your adjuvant therapies.
Okay, you completed the surgical staging. What about the final histological report, post-operative histology? You got it in the case.
So final histology report was tumor site in endometrium with a size of 8.5 centimeter with FIGO grade 2 with the myometrial invasion more than 50%. There was no uterine serosa involvement and lower uterine segment involvement or cervical stromal involvement or lymphovascular invasion. And 12 lymph nodes harvested, all were negative for tumor cells. So final invasion is empty.
Is the lymphadenectomy is adequate? Given for the number of nodes harvested, you mentioned about 12 nodes.
12
is
nodes.
it adequate to stage?
Pelvic lymph nodes, it's adequate, sir. But if the number of pelvic nodes is taken more, then chance of getting at least 1 micromet is high, like 21 to 25 nodes if you take. Otherwise, it's adequate nodes.
It is adequate. Okay.
Isn't this what is the number of nodes that you need to actually harvest in your pelvic lymphadenectomy?
It is, I think, 12 on each side.
6, yeah, totally I think
Six,
it's fine. 10 is-
6 on each side. So,
6 on each side.
Okay. So you got a stage 1B grade 2.
yes, sir.
What do you want to do for this patient after this?
Yes, sir. After this, I wanted to plan for a adjuvant therapy, sir. Adjuvant therapy in the form
So first of all,
regi-
tell us in which risk stratification group it is.
That she come into, yeah. So how do you plan your adjuvant therapy for this patient? Based on what?
Risk stratification.
She
What is
come
the
in-
current risk stratification for the endometrial cancer adjuvant treatment?
she come into the intermediate risk factor, sir.
Yes, if we are doing 3-tier staging, then it will come into intermediate. If we are following the 2-tier staging, then it will fall into
Low risk category.
this will
No,
not fall
2
into
tier will be
this-
grade 2 will be a high risk. No?
High risk. Okay.
Grade 2 will become, sorry, a high grade.
Yeah, and look at your tumor size.
A tumor size is more than 2 centimeters, so it is like high risk.
Okay.
So before that, with this histopathological report in your hand, would you plan for any molecular classification or molecular stratification in this endometrial cancer to plan your adjuvant treatment in a better way? Will it help?
Yes, so the Cancer Genome Atlas has now come up with the molecular classification into 4 groups. In that, if whole ultra mutated, then adjuvant treatment is not required in stage 1A and stage 1.
But stage 1B, when you have a stage 1B grade 1, do you really need to have your molecular classification done?
In this case, actually, it needs to be anyway. Adjuvant treatment needs to be given, sir. More than a deep myometrial invasion is present.
So it's a low grade 1B, isn't it? So what adjuvant treatment are you going to give her?
The pelvic recurrences are will be the commonest thing. So
Pelvic?
will be given.
Is it?
No, not pelvic, vaginal recurrences. So vaginal brachytherapy, intravaginal brachytherapy will be given.
Will suffice. Yeah, if at all you're going to give. So when do your molecular markers really help?
It helps in the early stage disease, like in stage 1.
Is it early stage? Or is it for high risk patients?
It helps in both ways, sir, because in the low risk patients, whether we can avoid, and in the high risk patients, whether
low risk you're going to avoid anyways.
Avoid.
Low risk you're going to avoid anyways. So
Okay,
you think that your low risk patients are going to become high risk based on your molecular classification, or do you think that your high risk patients are going to become low risk on your molecular classification?
Mostly the high risk patients we classified can become a low risk classification according to the molecular classification, sir.
Okay. Right.
We have 5 more minutes for our discussion.
Okay, so based on this, anything else you want to add on the adjuvant therapy that you need to be planning for him? Or
I will check if the patient was coming in the moderate intermediate risk, high intermediate risk, then I would have added the pelvic RT also.
She's not coming. So for this patient, we don't need it.
This patient will not come.
Okay. So how will you follow up the patient after this?
This brachytherapy will be given within the 12 weeks time, sir. So once the wounds healed, we'll be sending to radiotherapy. Once it is done, then we'll be seeing her in every 3 to 6 months for the first 3 years with the clinical examination. And
what clinical examination will you do?
We do abdominal examination, also the pervaginal examination and perrectal examination, sir. Whether any mass is seen in the vault or any mass felt in the POD also will be looked for. Depending on the clinical examination and findings, we may ask for imaging. Otherwise, it is not indicated in the initial period, sir.
Okay.
Okay, suppose if the patient is a 40-year-old patient, wants to have a fertility preserving procedures, so what precautions? Whether it's a fit case, this 1B disease, if fit one for fertility preserving procedures.
That will not be coming under the fertility preservation criteria, sir. It should be well differentiated, grade 1, confined to the endometrium disease. In those cases only we can go for, after complete curettage, we can go for fertility preservation with the progesterone therapy. But in this case, it is like this case, it is not ideal for even if it is in a fertility time.
Any questions, Jay?
Yeah, I think this is fine for endometrium, sir.
And we are on time, I think.
I think, yeah. So anything else from the panel? I mean, anything else is there on the chat box? I think we have.
There are another couple of two or three.
I think somebody's asked about
you-
whether the peritoneal washing report on your pathology it has not been mentioned.
Not
So
mentioned.
would you like to
Should be
ask
done.
your pathologist when you gave your cytology?
Okay.
Is it
Right,
important?
Yes, sir. It is important, sir, because both FIGO and NCCN says peritoneal cytology should be done.
Should be done, but it will
But
not
if it is
impact-
positive,
it will not
are you going to
adjuvant
change your
therapy.
risk?
No, sir, because alone a peritoneal cytology will not change the stage, and also it will not reflect in the survival difference. But usually, when it is along
When it
with an extrauterine disease, there is a chance that it can also deposit and independently grow in the peritoneum. But isolated peritoneal cytology doesn't have a significance.
Okay.
What is your opinion on use of manipulators for minimal access radical hysterectomy?
Sir, in carcinoma endometrium, we cannot use a uterine manipulator, sir.
Yes, it
Then
should be
for
avoided.
when can you use it? Which malignancy will you use it then?
In malignancy, yes, sir. Malignancy, we cannot use a uterine manipulator. In benign cases, we can use a uterine manipulator.
Myoma screws?
Myoma screws also contraindicated in.
Morcellator?
Contraindicated in.
Absolute
Morcellators?
contraindication.
Morcellator also is contraindicated, and it should
No.
not be used as per the FDS already given a black box warning for using of morcellators.
Morcellator black box warning was not for endometrial CA. Okay, anyways.
It is for the sarcomas.
Right, yeah,
Sarcomas,
okay.
sir.
Leiomyosarc. Fine. Good.
We'll cover the rest of the questions in the third session after your expert talk, Sujay sir.
Yeah, sure.
So before we conclude and you load up your presentation, I request Dr. Amish sir to kindly give his remarks on his performance, and then followed by him by you, Sujay sir.
Yeah, so I'll so he performed very well. I think he would score 8.5 or 9 out of 10. Very well presented, very well spoken, very good confidence, very good body language. Yes, he did pretty well.
Sujay sir.
Yeah, so it was a good presentation. My only thing is that, yeah, again, anyway, you knew this is an endometrial cancer discussion and all that, but I think you need to be a little wider with your presentation, keep your differential diagnosis in your mind, and take it and present it like you actually don't know what the case is about. I know it can be difficult, especially in a scenario like this, when you know that it's all about endometrial cancer and you are presenting a case of endometrial cancer. But what actually many times lacks in the exam is you do not know the differential diagnosis, and you are so much on track that you are not able to widen your scope. So you need to start thinking about, you need to have benign conditions, infectious diseases, everything in your background when you start your history at least. You can always rule down and come down to a malignancy at the end of your examination. But at the start, like how you do in your MBBS, always keep your mind open and have a lot of differentials in your mind, because that is what examiners may go into.
Always think as if you're sitting in your own OPD. What would you have done had that patient come to your OPD? And always examiner answer the examiner as if he is the relative of the patient.
Yes.
Okay. You just don't think he's asking the question, think he's asking his queries.
Yes.
And answer as you would have answered inside your OPD. You will sail through.
Ramesh sir, I wouldn't ask you to comment because he's a student, but any tips for the rest of the students if they get this case?
As Sujay said, they should keep their mind open, especially regarding the differential diagnosis, etc. It should be very, very much.
So thank you, Jeevan. And now I request Dr. Sujay Susikar to kindly share his screen and deliver his expert talk. I request Amish sir and Ramesh sir to kindly stay till the end, because we'll have a Q&A with the examiners at the end as well. Thank you. Over to you, Sujay sir.
Yeah. So thank you very much at the outset for this. I think we've covered most of the important points in your discussion. I'd like to thank the academic council and the senior office bearers of the IASO for giving me this chance. So I will basically be going through my topic today is on contemporary management and controversies. So we have touched upon a few controversies in our already on our case presentation. So I'll be brief and try to give you the current evidences and what is happening today, because I think endometrial cancer is something which has seen a lot of change in the last 2-3 years at least. A lot of things coming which is going to be possibly practice changing in the near future. So at the outset, we know that this is the most common gynec malignancy in the West, comes third as per, but sometimes many of our urban registries are recording it second. And what we have to know is there are many areas of controversy in the management of endometrial cancer, especially with adjuvant treatment recommendations. And today there is a large strides which are happening in the understanding the biology, which may possibly prove to be practice changing in endometrial cancer management. So the first thing is I've just briefly touched upon molecular markers because these are the most happening things. I know it can be a little stale, but we have to understand that the Cancer Genome Atlas project identified that there can be a very varied set of molecular groups of endometrial cancer, and they behave very varied based on their prognosis compared to the regular histopathological thing that we do. So they found out that there were different groups. One was the polymerase epsilon mutated tumors. Then you had a P53 abnormal tumors, and you had those which had microsatellite instability. So now what we are currently using is we are not able to use a genomic classification of all the tumors that you see in clinical practice. It cannot be practically feasible. So then we have started using a surrogate markers by two main studies where they started testing for 3 immunohistochemical markers and 1 mutation analysis of the polymerase E exon categories. And they have classified into 5 categories, which can be either ultra mutated with pathogenic pole mutations, or it can be hyper mutated with microsatellite instability, or it can be P53 abnormal, which is one of the most worst prognosis types in the high copy number. And you have low copy numbers, which has got a no specific molecular prognostic type. And you have multiple classifiers when you cannot categorize into any of these based on the immunohistochemistry. So this is what it is based. So on the right, you can see the 4 categories which were based on the Cancer Genome Atlas projects. And that is how it is being translated using simple immunohistochemical tests in the laboratory, which can be done on a every case-to-case basis. So for everybody, the pole mutation analysis is done. Then you do MSI immunohistochemistry for just 2 markers, MLH1 and PMS2. And then you do a analysis for P53. So based on this, if P53 is high, it is seen that most of these behave like serous carcinomas, even if they are high-grade endometrioid on our pathology. This is what, these are the 2 studies which have now come into play. One is your TransPotec and then is your PROMISE studies. So these have integrated these molecular classifications, and now you have T53 mutant, like I told you, or the MSI unstable, and then you have a pole mutant and your no specific molecular. P53 is the worst prognosis, and it is said that all P53, even stage 1 tumors with P53 mutation should be treated as high-risk category patients, while even stage 3 and 2 patients with pole mutant, they can be considered as low risk and can possibly avoid adjuvant therapies. So this is the way in which it is done, the 4 classifications, which is currently come up. This is as new as 2016 it has come up, and now it is coming into practice after 2019. So you can see now the basic after your POTEC, it was either low grade, low risk, intermediate, high risk, and advanced metastatic disease. And the molecular classification now we integrated into this, and that has changed in that even stage 1 to 2, which used to come under high risk, high intermediate, and high risk, has now become a low risk if they have a pole mutation. And those even some advanced stages which have got this thing go into a high, even early stages with either MMRD or those with serous like P53 abnormalities move into high risk, even if they are in stage 1. So this is just about that. I will touch upon this and their significance in the post-operative adjuvant therapy management later on. But now coming on to the current recommendations and the guidelines for what is important for your pre and intraoperative workup. What is important is that a histopathological tumor type and grade should be done in every endometrial biopsy, and endometrial biopsy is a must before taking up a patient for a surgery. A preoperative should also include a family history. You should have a general assessment and even comorbidities, good old geriatric assessment, clinical examination, including a thorough pelvic examination. And before you take up the patient for surgery, either you do an expert transvaginal scan or you take the patient up for an MRI. If you do not have an expert transvaginal scan, because it is now seen that an expert transvaginal scan can give you all the details that your pelvic MRI can give you on the local factors. Then additional imaging modalities will be based on the clinical and your pathology and your risk factors based on your histopathology or biopsy and on your clinical and your local imaging studies. You can do a CT or MRI of the abdomen and pelvis to know the local stage. A PET CT is of use only when you suspect extra abdominal disease. And earlier in the 90s, intraoperative frozen section was being predominantly done as per some Mayo protocols to assess for myometal assessment. Today, it is frowned upon. It should not be done because it actually denies specimens for further proper myometal assessment, and it is very variable on assessment of myometal invasion using an intraoperative frozen section. So what is the standard surgical procedures which should be done today? The standard surgery for early stage endometrial cancer is going to be a total hysterectomy with bilateral salpingo oophorectomy. A vaginal cuff resection was advocated a while earlier. Now it is not required in early stage endometrial cancers. An infracolic omentectomy needs to be done for stage 1 if it is serous carcinosarcoma or undifferentiated carcinomas. A surgical restaging may be considered in some patients who have not undergone a previous staging if they have a high intermediate risk or a high risk, if it is going to have an implication on your adjuvant therapy plan. If you feel that it is a high risk even without surgical restaging, then those patients may not require surgical restaging. Coming to the approach, this was the controversy earlier, but now it has been proven without doubt, even as early as 2010, that minimally invasive surgery, either laparoscopic or robotic, is the preferred approach today. And what has to be specially taken care of is any intraperitoneal tumor spillage, including tumor rupture, should be avoided. In so much that if your vaginal extraction risks a uterine rupture, then you may have to do a laparotomy to remove just the tumor. Tumor metastasis outside the uterus and cervix, excluding lymph nodes, are relative contraindication for minimally invasive surgery as on date. Coming to lymph node staging is something which has been visited, not revisited, and there are so many controversies surrounding this. Earlier, it was based on your GOG 33 retrospective reviews, it said that there is a therapeutic effect of lymphadenectomy, especially in intermediate high-risk disease. But now we have 2 randomized controlled trials which have failed to show a survival benefit because of lymphadenectomy alone. It may possibly help us in identification of lymph nodes which are positive for adjuvant therapy. Para-aortic lymphadenectomy again has been very controversial, especially because of the challenging nature of the surgery and the complications that can be associated, especially because of major vascular injuries. But you have to assess whether it is needed based on the risk of isolated para-aortic lymph nodes that you suspect. This will be based on your imaging and your high-risk features. Earlier in the 90s, there was a concept of individualizing lymphadenectomy and deciding on patients who may need lymphadenectomy and for whom you can avoid. This is when they said that early grade 1 and 2 or less myometal invasion and patients who got a tumor diameter of less than 2 centimeters, you can avoid an lymphadenectomy. Today, it is not so. With the advent of sentinel lymph node evaluation, all patients will need some form of lymph node evaluation. So coming to the latest is that sentinel lymph node biopsy for endometrial cancer is here to stay, and it has been proven by many studies like your SENTI-ENDO, your FIRES trial, and your SHEG trial to say that it is equal, if not better, than lymph node staging using a proper therapeutic dissection. So this can be considered for all patients, especially with those who are low risk and intermediate risk disease, and you need not do a systemic lymphadenectomy. It is also an acceptable alternate today in some stages 1 and 2 tumors. The ICG is the preferred. I think we've already discussed this, and you can do a tracer reinjection if you're not able to see on one shot. The site-specific lymphadenectomy is done if the sentinel node is not detected on that stage. And all these sentinel nodes today, the standard of care is you send them for a pathological ultra staging, and like we have discussed, it is ultra sectioning to 2 to 3 millimeter cuts and using immunohistochemistry to identify cytokeratins. So this is the famous MSKCC protocol or the algorithm which should be followed if you're going to do a sentinel lymph node biopsy, where you will do a retroperitoneal evaluation and excise all mapped sentinel lymph nodes for ultra staging. Any other suspicious nodes which are enlarged will also be regarded whether they are going to be mapped or not. If there is no mapping on any hemipelvis, you do a site-specific lymph node dissection. A para-aortic is being left to the attending's discretion. So if you do a systematic lymphadenectomy, then a pelvic and a para-aortic infrarenal lymph node dissection can be done. You look for both the presence of macro and micro metastasis. Both of these are considered metastatic as far as your decisions for adjuvant therapy is concerned. The prognostic significance of isolated tumor cells, which you are now identifying with ultra staging, where it is less than 2 micrometers, is still uncertain. If pelvic node involvement is found intraoperatively, again, one thing which has now been definitely proven is that a complete systematic lymph node dissection need not be done. You can debulk because a complete therapeutic, your systematic lymph node dissection does not add to your survival advantage. Then coming to one more controversial thing, earlier all endometrial cancers had to have the ovaries removed. Now there is some meta-analysis and SIR reviews which have shown without doubt that you can actually preserve the ovaries in stages 1 and 2 endometrial cancer, especially in very early premenopausal women. In women less than 45, it has been shown that they actually have a survival advantage, avoiding the risks of early ovarian ablation. So this can be considered in premenopausal women with low grade and less than 50% myometrial invasion with no obvious extrauterine disease. However, you should do a complete salpingectomy, but it is not recommended for patients who have a family history of ovarian cancer, especially those who suspect BRCA or Lynch syndrome. Then coming to one more area which was a little controversial, touchy, and now there is a meta-analysis to say that even in clinical stage 2, a total hysterectomy is sufficient. But however, you can do a little more extensive procedure like a radical hysterectomy if you have to do that to achieve a negative surgical margin. A very little cervical stromal involvement does not actually warrant a radical hysterectomy. And then in medically unfit patients, in rare cases, you can do a vaginal hysterectomy in those patients who got uterine confined disease. If they are not fit for surgery, you can use definitive radiation. In high grade or high risk patients, you can use external plus brachyradiation. In low grade, brachytherapy alone can be considered. In patients who are not even fit for radiation, then you can use some form of hormonal therapy. Then coming to fertility preservation, this has to be done only in specialized centers where there is a good person who got a good protocol for fertility preservation after management of CA endometrium. So this can be done only in patients who got atypical hyperplasia or endometrial intraepithelial neoplasia or in grade 1 tumors with absolutely no myometrial invasion. You should preferably do a hysteroscopy after your DNC and make sure that you've completely removed all the tumor from your endometrial cavity. And then you can use fertility preservation technique using either oral medroxyprogesterone and levonorgestrone IUCDs. You have to assess the response after this thing with the hysteroscopy and imaging serially. And the patient has to be on strict surveillance. And once she has completed her childbearing, you have to do a hysterectomy and a salpingo-oophorectomy. Then coming to the synchronous presentation of low-grade endometrial, this happens in up to 3 to 5% of patients who got an endometrioid, endometrial, and ovarian carcinoma. Now, recently, there's a WHO criteria which has come up in 2020, which says that if both the tumors are low-grade, there is no more than superficial myometrial invasion in your endometrium, and there is absence of LVSI or additional metastasis, then actually adjuvant therapy can be avoided in patients who got stage 1 endometrioid and stage 1 ovarian cancer, endometrioid. Then coming on to the most contention area today, this is something which is very vast. So I'll just be touching upon what we will need to know as surgical oncologists regarding low, intermediate, and high risk and based on adjuvant therapy. So adjuvant treatment is going to be based on your prognostic groups, whether they have a low risk of recurrence, an intermediate risk of recurrence, a high intermediate risk, or high risk. So now today you have a molecular classification which has been amalgamated into these groups to classify again into low, intermediate, and high risk to base your adjuvant therapy decisions. Low risk patients are those who got stage 1A low grade disease with no lymphovascular invasion. With the advent of molecular classification, this can include pole mutated endometrial carcinomas, and they should have no residual disease after stage 1 and 2. Or it can be stage 1A only, those who've got a mismatch repair deficient gene. In these patients, you can actually avoid adjuvant therapy because they have a very low risk of recurrence. Intermediate risk is going to include stage 1B low grade, or it can be stage 1A with high grade, or it can be a stage 1A non-endometrioid. And with your advent of this thing, you can have P53 abnormal come into an intermediate risk if it is stage 1A. In these patients, you can use adjuvant therapy. Adjuvant vaginal brachytherapy is sufficient, has been proven to be equal to external pelvic RT in intermediate risk patients, except in P53 abnormal patients who you have to give an adjuvant external beam radiation. High intermediate risk is going to be higher stage, and it is going to be stage 1B with higher grade. In these patients, you can use, if you have only endometrioid, you can use adjuvant brachytherapy. But if there is substantial lymphovascular invasion, then you can use external beam radiation. And you have patients who are pole mutation will count a lower risk, they will become low risk. And if it is going to be P53, they will need both chemotherapy and radiation therapy. High risk is going to be treated with external beam radiation with concurrent or adjuvant chemotherapy based on the institution protocol, just meaning that the patients will need chemotherapy and radiation. All carcinosarcomas are going to be treated as high-risk carcinomas. Then coming on to what is the current this thing for radiotherapy, it can be in the form of external beam or vaginal brachytherapy. External beam, the current thing is an IMRT is preferred because of the pelvic nature of the disease. And you usually give 45 to 50 gray over 25 to 28 fractions over 5 to 6 weeks. And if there is microscopic residue, where you suspect there is microscopic residue, then there you'll have to give a boost to achieve a dose of 55 to 60 grays in those area. If there is macroscopic bulky disease which is left behind, then there you'll have to escalate your dose up to 66 gray. A vaginal brachytherapy usually is given with high dose radiation, either with 21 to 24 gray in 3 to 4 fractions. Systemic treatment, the current chemotherapy which is used now is carboplatin and paclitaxel. In second line, in patients who fail immediately after chemotherapy with carboplatin paclitaxel, then you will have to go in for weekly paclitaxel or anthracyclines. Hormones can be used in low risk disease, where you can use either progestins, or there is also a role for aromatase inhibitors today as alternatives after that. Today, there is a huge role for PD-L1 inhibitors as a second line chemotherapy after failure, especially in microsatellite unstable high tumors. Now coming to the surgical role in advanced disease. Today, again, there is a lot of contention with this, but current evidence says that for clinically overt stage 3 and 4 disease, you can still do surgical debulking, including all the enlarged nodes. If it is not feasible to remove that, then you can give primary systemic therapy and then go in and do surgery as an interval setting. And only enlarged nodes can be resected. There is no need for a systematic lymphadenectomy to complete the complete area. It does not have a survival advantage. In patients who have an unresectable primary because of local resect, then in those patients, you can plan some form of combination of radiotherapy and chemotherapy. In patients who got residual or para-aortic lymph nodes after surgery, then you have to give them a combination of chemotherapy and radiation. Or residual pelvic disease, you will have to have an individual approach and form either radiation or chemotherapy or a combination of both, which is usually given. Today, with the advent of cytoreductive surgery for ovarian tumors, a lot of extrapolation is being done for endometrial cancers, which are presenting with intraperitoneal disease alone. So that most of it is recent meta-analysis shown that you can actually achieve a good optimal tumor debulking, and that will give you a better survival. Here again, the goal of cytoreduction should be similar for ovarian cancer, where you want to achieve no gross residual disease. Again, neoadjuvant chemotherapy may be considered before interval surgery, similar to ovarian cancers. In recurrent disease, those who have no radiation, there again you can do surgery if you can completely remove the disease without much morbidity, or you can give radiation. In patients who are pre-treated with radiation, then ideally you can go ahead for radical surgery, including excenteration, if you can achieve a complete resection with clear margins. If you will not be able to achieve margins, then you can explore options like radical re-irradiation. If there is oligometastatic disease, then you can consider some radical therapy, local therapy, either in the form of surgery or radiation. Systemic therapy, again, like I've told you, it's in the form of either hormone therapy, chemotherapy, or anti-PDL based immune therapy. So with this, I will conclude. I think I have been brief and just touched upon what are the current this thing. So we have to understand that today endometrial cancer has become something which is includes several biologically different tumor types. Early stage disease, the current thing is surgery, which is followed by adjuvant therapy based on your prognostic risk stratification. Today, incorporation of genomic prognosticators has also come into your prognostic risk stratification to guide your treatment. In advanced disease, though it is currently not curable, chemotherapy and systemic therapy will remain a mainstay, and the role of surgery is being explored, including cytoreductive surgery. Newer directions, especially after the advent of microsatellite instability proof, has come to be in the role of PD-L1 inhibitors and anti-PD-L1 therapy. So with this, I will conclude. I hope I have just touched upon, it was not elaborate, but I've just tried to touch upon what are the current things which are there. Thank you very much.
Thank you so much, Sujay sir. You literally took over from the case discussion and from the first slide started on the things that are required after that. So you did cover most of the questions that we have for the experts, but because there are questions on these topics specifically in the chat, it would be worth repeating certain questions, the answers to certain questions, so that there are clear take-home messages for our participants. My first question is, indications of type 2 or type 3 radical hysterectomy in endometrial cancer today, what would be your indications? Amish sir.
So if cervical stoma is involved to the full thickness, then I would prefer a type 2, type 3 hysterectomy. If it is involved only to the inner extent, only around the endocervical canal, then type 1 also can be done.
Okay. And for more than 50% myometrial invasion, sir?
That does not impact type of hysterectomy.
Correct. Ramesh sir and Sujit sir, would you confirm these statements?
Yes, sir. We fully agree with Dr. Ramesh. Yeah.
Correct. So our next question is to Ramesh sir. Sir, what would be your contemporary indications for PET CT in endometrial carcinoma today? Would there be any?
So suppose if the conventional imaging like vaginal ultrasonogram or your yearly pelvic MRI shows a possibility extra uterine disease or multiple lymph nodes, bulky lymph nodes, then obviously PET CT to rule out the distant metastasis and other diseases.
Right, sir. Sujay sir and Amish sir, any inputs?
True.
Only if the MRI is suggesting stage 3 disease, bulky stage 3 disease, only then PET will come into play.
Right, sir. Our next question is to Sujay sir. Sir, when do you decide on the extent of lymphadenectomy? When does that take place? Is your stratification happening before the patient is induced based on the imaging? When you have the biopsy report, or would you do it after the frozen section analysis during surgery?
See, like I think I mentioned in one of the slides, the decision for lymphadenectomy is before the patient is on the table. After imaging and your biopsy report itself, you have made a decision. Even before the patient is taken up for surgery, you have to make a decision on a lymphadenectomy. A frozen section today is totally frowned upon to make a decision for lymphadenectomy. The only indication for possibly using a frozen section is to confirm malignancy, if at all. The role of a frozen section to assess myometrial invasion or depth of invasion is not there. The frozen section is not a useful investigation to make out myometrial invasion or any high risk factor to base your decision on a lymphadenectomy on.
Right. Amish sir and Ramesh sir, would you concur with that?
Yeah, definitely.
Okay.
Yes, mentioned in the slides also.
Yeah. And next question to Amish sir. So the significance of a fluorescent lymphatic, which is leading to a non-fluorescent lymph node. What would you consider that during the SLNB?
Yes, it will. It's part of central lymph node. So all lymph nodes in which fluorescent lymphatics are leading to, all enlarged nodes and all fluorescent nodes, all three will be removed as part of ultrastage.
And the lymphatics as well?
No need to remove lymphatics.
Okay. And last question to Sujay sir, and I think he covered it during his talk, but for the pain of repeating, sir, if I request you to, what would be your protocol of treatment today for an advanced stage 3 endometrial cancer?
So that's what, see, basically you have to be very clear about when you're going to identify it as stage 3. It can be clinically and your imaging based, it can actually be a stage 1 or a 2 with a few nodes, which you identify as node positive after your surgery. In those patients, it's very clear. You do your surgery as it is required now. You do a sentinel node biopsy or you do a surgical or lymph node staging, identify it as stage 3, then the patient goes for post-operative chemoradiation. In patients who on imaging itself have got bulky nodes, if they are operable, if it is an operable disease, then you would like to go in, remove all those nodes along with your standard hysterectomy, and then follow it up with adjuvant therapy. If, of course, you feel that your nodes are not going to be resectable, or you have peritoneal disease or anything in the pelvis which is not going to be resectable upfront, then you can think of preoperative chemotherapy. And there it is being almost treated like a carcinoma of the ovary, where you would like to give chemotherapy, try to do surgery, and then possibly give adjuvant. Because the role of surgery after chemoradiation becomes very tough, especially when it's going to be nodes.
Any inputs from Ramesh sir and Amish sir?
Fully agree. So whatever they say.
Right. So I would like to thank all our 3 examiners for patiently answering these questions and repeating a few so that we can have clear take-home messages. I request our secretary, Dr. Sharad Desai sir, to kindly deliver the vote of thanks on his behalf.
Thank you very much, Srijan. Thank you very much for the nice. Very nice.
Thank you. Thank you very much.
Sharat sir, are you there, sir?
Yeah, I'm there. Thank you, Dr. Srijan. And it was a great ending for a year-long sessions of master classes. Dr. Jeevan, you have done well, and it was a good presentation from Dr. Sujay Susikar. I think, Sujay, you attended the NatCon Goa when you were a young person, and I am seeing you after a long time. I don't remember seeing you in between. Nice to see you again.
Thank you, sir. You were a student then, and now we're slowly moving on.
Nice meeting you, Dr. Ramesh. Also, all of you have examined the student well, and thanks for participating in the ISO masterclass. I must also thank all the past presidents for conducting all the master classes so well. And again, Srijan, a personal thank you for doing a lot of work for the ISO. I'm very much impressed, especially as the consistency, because I am a strong believer in consistency. And you have given the ISO 25 master classes continuously with good amount of viewership. And I really appreciate it from this. Of course, Dr. Rao also has to be given the credit. And I thank Dr. Arnab sir and all my colleagues from the executive committee. And this being my last masterclass, I must say goodbye and good luck to all of you people, and keep continuing doing the good work. Thank you, people, for keeping me in the room.
Thank you.
Thank you from very quick thank you from my side as well, because my term is finishing as well. It was really an honor to have these PG master classes. Each one of them was brilliant, like I said, and even this one was brilliant as well. The faculties have been superb. The expert talk, the interaction, the way the presenter presented once again, and all the credit goes to obviously the academic council. You have done a brilliant job, led by Dr. Subramanian Rao, ably assisted by Srijan Shukla. Even last night I had to tell him that we need to have a special flyer for this 25th Jubilee celebration, and he got it ready within a few hours. So really hats off to you, and the way it has been conducted throughout seamlessly, it's really praiseworthy. A big round of applause to all of you.
Thank you.
Thank you so much, sir. Yeah.
And thanks to ISO EC, including Sharat Desai, all the past presidents. My kudos to all of them. Thank you very much. Enjoy the rest of the day.
Thank you so much, sir. And Arnab sir and Sharat sir, our last ISO meet is not today, because on 23rd October, we'll be having a best of ISO masterclass session at 5 p.m. So, which will include 6 selected best presenters from the last 24 classes. Today's class was omitted for it. Today's class will be included in the next series, and they'll be showcased in NatCon, and top 3 of them will be selected by the NatCon committee, and awards will be given to them. So our last meet of this series of masterclass would be on 23rd. We hope that all of you make it there for that show. With that, we would like to conclude today's webinar. I thank everyone from my side. Good night, and see you next time.
Thank you. Good night.
Thank you. Thank you very much.